Okay, so I'm hunkered down in my office upstairs. I have the sitter downstairs with the kids, and I have the dog locked up so he doesn't eat the sitter. So I think we're ready to go ahead and start shocks. So our exemplars for shocks, we've got septic shock, anaphylactic shock, hypovolemic, cardiogenic, and neurogenic. The good thing about shocks is that there's a lot of overlap with SIRS and MODS. Typically, if a patient has, sepsis, for example, and it's left untreated, they could go into septic shock, and then the systemic inflammatory response system is activated, and then the end result would be multiple organ dysfunction syndrome. So there's a lot of overlap between the content that we're going to be talking about. Okay, so we'll start with cardiogenic shock. So cardiogenic shock is anything that would cause a problem from the heart receiving blood flow. So some common reasons we have for that would be if the patient's having an MI, if they have end-stage heart failure, or other reasons would be, cardiomyopathies, cardiac tamponade, those types of reasons. So cardiogenic shock, early manifestations are tachycardia, so the heart speeds up to try to compensate for that decreased cardiac output, hypotension, and then a narrowed pulse pressure, which is basically calculated by subtracting your diastolic blood pressure from your systolic, and it's considered low if it's anything less than 40. And basically what that means is that your heart spends 2/3 of its time in diastole. So if you have that high diastolic pressure, that's kind of describing your venous filling. So the heart is having a hard time bringing blood back to pump to the rest of the body. So we don't want that to be elevated for a prolonged period of time. And then lastly, our increased myocardial O2 consumption. So it's kind of a double-edged sword here. If the heart is having a hard time getting blood flow to it, the body will sense that and kind of respond by increasing the heart rate, which in turn requires more blood and more oxygen. So, more of a chance of the heart giving out, so to speak. So upon physical assessment, what we're going to see, patient is going to be tachypnic. They might have some backflow into the lungs, causing some pulmonary congestion, some pulmonary edema. How that presents is going to be like frothy sputum. Sometimes it might be pink tinged, or just kind of, foamy in nature. They might be pale, diaphoretic, decreased capillary refill, or sluggish. And then because of decreased oxygenation, that tachypnea can cause some respiratory alkalosis, which can lead to anxiety, confusion, and agitation. If you have like an invasive, your Swan-Ganz, your pulmonary artery catheter, there might be an increased pop because of that, increased pressure for fluid volume overload. And then on your CVP, you might have a higher CVP as well. Because of the fact that the heart is needing more blood, more oxygen, body's, again, is going to kind of sacrifice the kidneys and decrease that urinary output. Okay, moving on to hypovolemic shock. So our reasons for absolute hypovolemia, so this is just a loss of some type of body fluid. So hemorrhage would be bleeding, or it could be a GI loss from excessive vomiting and diarrhea, one or both. Fistula drainage, diabetes insipidus, so inability to retain water. Hyperglycemia can cause this because of the osmotic properties, or just excessive diuresis, so overuse of diuretics, that can cause absolute hypovolemia. Relative hypovolemia is a little bit more complex. So this is that the body has enough fluid, but it's in the wrong spots. So this would be your third spacing, fluid moving into body cavities that normally have little to no fluid. So what we'll see with that, most common is your peritoneal space, or ascites. manifestations of hypovolemic shock are similar to cardiogenic shock. They're going to be anxious, tachypnic, tachycardic. However, with invasive monitoring, they have a decrease in stroke volume, decrease in pop, and then they'll have a decreased CVP as well. Urinary output is also decreased because, again, there's not enough blood or body fluid to do the body's work, so it's going to sacrifice the kidneys. If loss is greater than 30%, if their estimated blood loss, it will be replaced with whole blood. So neurogenic shock, this one's my favorite. This one is kind of, in its own category. And you'll see with the shocks, there's some overlap with some of them. And then there's also some things that make them very unique. And that's the case with neurogenic. So this is a hemodynamic phenomenon because there's no explanation for why this occurs. It happens within 30 minutes of a spinal cord injury, typically, at higher level spinal cord injuries. So we're looking at T5 above, and then all of the cervical injuries can last up to 6 weeks. Can also happen in response to a spinal cord injury or spinal anesthesia. So results in massive vasodilation. So initially, the skin might look kind of flushed from that vasodilation. And then tissue hypoperfusion, ultimately impaired cellular metabolism, so that switching to anaerobic metabolism. So manifestations, so they have hypotension, but they have bradycardia. So unlike the other shocks, they actually become bradycardic as opposed to tachycardic to help with a compensatory mechanism. They also have something called poikilothermia, so they take on the temperature of their environment. So initially, because they have that massive vasodilation, they'll have that, that flushed look. But then after that fluid starts kind of reabsorbing, they're at risk for hypothermia because of that heat loss. They also will have dry skin. So with the other shocks, you'll see some cool, clammy skin, but with neurogenic, they have dry skin. Okay, so for anaphylactic, acute life-threatening allergic reaction. So this also causes massive vasodilation. However, it's very focused on bronchioles. So with that vasodilation, there is fluid infiltrating that area, including those vasoactive mediators, histamine, so on and so forth. And then there's also bronchoconstriction. So manifestations, patient's going to be anxious, confused, dizzy. They might be very pale, diaphoretic, sense of impending doom. They can't catch their breath. They might also have some chest pain, and this is commonly from the retractions that are occurring from trying to take a breath against that bronchoconstriction. And then they might also have incontinence. So this is unique to anaphylactic because of that fight or flight response is activated immediately, hence the incontinence. So more signs and symptoms, swelling of the lips and tongues, known as that angioedema. Wheating and stridor is due to that massive vasodilation and laryngeal edema. So it's the airflow trying to kind of get through in and out in that smaller space. May have allergic reaction responses like flushing, pruritus, itchiness, urticaria or hives, respiratory distress, and then ultimately circulatory failure if left untreated. So septic shock, is very unfortunately common. We see a lot of patients, not so much septic shock, but sepsis, I should say. So sepsis is an infection, and it's a systemic inflammatory response to documented or suspected infection. Very common sites that we see for this are urosepsis, so typically a catheter-related urinary tract infection or a CAUTI. Sometimes we'll see infections from a central line, and infections from a wound, infections from osteomyelitis. So it just depends on what the patient has going on. Severe sepsis is when the compensatory mechanisms, are working and they start to kind of not work as effectively. And then septic shock is you're treating it, you're giving them fluid, they're getting vasopressors and they're still not really responding the way that we would like, we consider that septic shock. And I'll explain more about that. So don't worry too much about this slide. It's just kind of a fancy way of saying that with septic shock, we're hitting that systemic inflammatory response system. So increased coagulation, widespread inflammation in the body. We see some capillary permeability, so some fluid moving out of the cells, formation of microthrombi, and then obstruction of microvasculature. So all of that histamine, all those inflammatory mediators are kind of activated. And in response, you'll see increased cardiac output because you have all of this fluid, but it's moving in spots where it's not supposed to be. And then a decreased systemic vascular resistance. So the body's kind of compensatory mechanism of vasoconstricting to increase that blood pressure goes away at this time. So major effects of this, we have massive vasodilation, maldistribution of blood flow. We'll see some shunting of the blood to the lungs and the heart, and then ultimately myocardial dysfunction, tachycardia, hypotension. Respiratory-wise, we have tachypnea, respiratory alkalosis, potential to go into respiratory failure, require mechanical ventilation from that increased capillary permeability. We also might have patients that the end result is ARDS from that fluid shift. Decreased urinary output, might have some agitation, confusion, anxiety, and GI dysfunction, GI bleeding, and paralytic ileus, everything that's associated with decreased blood flow to the GI system. So shock is categorized into 4 stages. So we're going to talk a little bit about the initial stage. So this may not be clinically apparent. So what's important is that we're looking at the MEWS. So modified early warning system, basically a charting system where you're going to document blood pressure, temperature, heart rate, respiratory rate, and labs. And certain things it'll pick up on as, trending. So if it's trending up or trending down, these are things that will be looked at to see if a patient's entering shock. It's really important to catch it in the initial phase because it's a lot easier to reverse if we can catch it early on. So in our compensatory stage, what we see because of the drop in blood pressure, that's characteristic of the shocks. This occurs because of the decrease in cardiac output. So the body tends to try to compensate for that by increasing the heart rate. Blood flow to essential organs, heart, brain, is maintained while blood flow to non-vital organs, kidneys, GI tract, skin, is diverted or shunted. And then if the lungs are trying to respond by becoming by you becoming tachypnic, this is trying to increase the amount of oxygen that's given to the blood. However, if there's that drop in blood pressure, there's areas of the lungs that may not be getting as much perfusion, so we'll see a VQ mismatch. So in the GI phase, we're looking at decreased blood flow, so risk for paralytic ileus, decreased peristalsis, gastric dilation, constipation are all going to be signs of impaired GI motility. Cool, clammy skin, septic patient might be warm and flushed. They're also the only patient that would probably have a temperature because they actually have a documented infection, whereas with the other shocks, there's no infection that's causing this. Then when we talk about our kidneys, so, just kind of to refresh, the renin-angiotensin system activation occurs at this point. In the progressive stage of shock, we start seeing the compensatory mechanisms start to fail, and there might even be some end organ damage. So your patient that was initially anxious, slightly disoriented, is now, suffering from profound confusion, maybe some lethargy. When it comes to the lungs, at this point, the lungs can only tolerate breathing so fast for so long. So our end result is ARDS and mechanical ventilation. with the cardiac system, that sustained hypotension and that hypoperfusion can lead to those weak pulses and ischemia of distal extremities. Now, the majority of shocks we're going to treat with fluids, except for that absolute hypovolemia. We might actually give whole blood and fluids. Another medication we're going to use is a vasopressor, such as Levophed. The problem with this is that it redirects that blood to where it needs to be, taking it away from the periphery. So it's not uncommon to see an ICU patient that has some cyanosis of the fingers and toes, not only from the shock, but from the medications that are being used. Patient also is at risk for dysrhythmias, myocardial ischemia, possible MI if they have some comorbidities. And we talked about the differences with the lungs, so that fluid permeability leads to pulmonary edema. They might have those moist crackles, that frothy sputum. With anaphylaxis, we still see that bronchoconstriction. Okay, so with GI system becomes ischemic. So at this point now they're at risk for ulcers, bleeding from those ulcers, risk of migration of bacteria, so bacterial translocation and potentially peritonitis, and then decreased ability to absorb nutrients. So at this point, if they were on an enteral feeding, at a slow rate and they were able to tolerate it, this would be a point where they might not be able to tolerate a tube feed anymore, might need to be switched to TPN. Also renal tubular ischemia, so our kidneys are affected, leading to AKI. This is worsened by nephrotoxic drugs, so our antibiotics, aminoglycoside classifications of antibiotics, your vancomycin, your gentamicin, those are going to are nephrotoxic, so those can further injury to the kidneys. We see, further decrease in urine output. Your BUN and serum creatinine are going to be elevated, and some metabolic acidosis from the kidneys being unable to reabsorb that bicarb as a buffer. Once it hits the liver, we've got some serious problems. Our effects from that are going to be jaundice, elevated, AST, ALT, loss of immune function, which is, can potentially be fatal with a patient that is septic, because it's the body's inability to fight off that infection. And then we have that risk for DIC and significant bleeding. In the refractory stage, it's very unlikely for patients to come back from this. The end result is MODS. So we have exacerbation of anaerobic metabolism. So there's, increase of lactic acid buildup. Their hypotension is unrelieved by medications and fluids. And then they're going to be mechanically ventilated at this point. Tachycardia worsens, and then once one organ system fails, it's not too long after that the organ systems start failing as well. Moving on to diagnostic studies, and then we're going to talk about interventions. So we want a thorough history and physical examination, and some factors that would make this patient at risk. For neurogenic shock, did they have a spinal cord injury? For hypovolemic, are there any obvious signs of bleeding? And then for our septic, is there, a cut or abrasion or something that could have become infected? I once had a patient who had cellulitis of the toe who ended up in septic shock because they couldn't figure out what was wrong, and the patient wasn't able to feel or even notice that this toe had become severely infected. So we want to make sure we get that thorough history and physical examination done. There's no studies, no single study to determine shock. We're going to check the lab values. An elevation of lactate is going to kind of say we're switching to that anaerobic metabolism. A base deficit might kind of show some decrease in kidney function. Additionally, we'll get a procalcitonin level, and what this does, if that's elevated, it shows that the infection that they have is bacterial in nature. So it's kind of a clear cut, definitive, this patient is in sepsis. Also going to get an EKG, continuous EKG monitoring. This can help identify, this along with your chest x-ray can help identify any reasons why a patient would be suffering from cardiogenic shock. And then potentially have some advanced hemodynamic monitoring, so placing an art line for more accurate blood pressure, a CVP, or a PA catheter. Okay. So for interventions, the cornerstone of therapy for septic, hypovolemic, and anaphylactic shock is going to be volume expansion. You're probably wondering why, if they've got a decreased blood pressure with cardiogenic shock, why we wouldn't give volume. And reason being is that the heart can't actually compensate for that. So in actuality, if it's an MI they're suffering from, we might give a vasodilator to help dilate those coronary arteries, being sure to watch the blood pressure because we don't want it to drop too much, but it's really important that our heart is getting blood flow. So for these types of shocks, septic, hypovolemic, and anaphylactic, what we're going to do is have 2 large bore IV catheters, so 18 gauge or smaller, potentially an IO or CVC placed, and then we're just going to give some crystalloid solution, so normal saline lactated ringers, and potentially then colloids like your albumin that are going to help, especially with cases with relative hypovolemia. It's going to help pull that fluid back where it belongs in the intravascular space. So with fluid responsiveness, our gold standard finding that it's been effective is going to be your urine output. So if your patient's making urine, the kidneys are being perfused, and that means that the body isn't having to sacrifice them to shunt fluid elsewhere. For oxygen and ventilation, so we're gonna, put the person on oxygen as needed. If it's related to decreased hemoglobin, then we're going to, potentially do a blood transfusion. And then if it's caught kind of more later on, mechanical ventilation with intubation is an option as well. So talking about cardiogenic shock specifically, this is going to be where our vasodilators are used, and these decrease afterload, so that fluid volume overload that the patient is experiencing is going to help with that. Again, we want to maintain that MAP at 65, so that blood pressure, we want to keep it, where it's able to do the body's work, but we definitely have to still make sure that the heart is getting perfused. So I'm sure you're kind of noticing that there's a lot of overlap when we talked about mechanical ventilation with a lot of these symptoms and then a lot of these interventions. So it's kind of nice, a little bit of a review. So again, we want to make sure that they have nutrients to meet the body's needs. So it should be started within first 24 hours. Enteral feedings it's the route of choice, and then it's what we call trophic feeding, so slow drips of small amounts of nutrition, see if they're tolerating it, and then we can titrate it up to a goal rate. So physicians will often write like, goal of 50, and this is advised to them from dietitians and nutritionists. This isn't a number that they just come up with and think, oh, I think the patient needs this. No, it's all kind of figured out to see what type of feeding solution is required, and then the amount per hour that the patient requires. It's not always possible to get it completely up to goal, but we definitely want to try to titrate it up as it's tolerated. Weigh patient daily, we want to do same time, same amount of things on the bed, kind of be the most accurate. They might have some weight gains because of the third spacing of fluid. It doesn't necessarily mean that they are okay fluid-wise. It's just, they have that relative hypovolemia. But then looking at their calorie needs, it's not going to be, like the best indicator of, how well perfused they are, so to speak. Okay, so for cardiogenic shock, we want to treat the underlying condition. So if it's an MI, they're going to have to go, to the cath lab, potential for angioplasty or a CABG. If it's something valve related, they would need a valve replacement. If it's end stage heart failure we're talking about, then an LVAD might be an option. They can also be given inotropic agents to kind of help increase that cardiac output. So it just depends on what the patient has going on. So for medications, they might be given nitrates to dilate coronary arteries, diuretics to reduce the preload, vasodilators to reduce the afterload, beta blockers to help reduce the heart rate, and all of the other shocks. We actually want to keep the heart rate elevated because, again, it's that compensatory mechanisms. But with cardiogenic shock, that heart rate beating so fast, that's going to increase that myocardial demand, which the body doesn't have to give it. So we want to make sure we try to keep their heart rate controlled. Okay, so for hypovolemic shock, we want to stop loss of fluid, restore circulating volume, so direct pressure to any bleeding wound. If it's nausea, vomiting, diarrhea, then we want to address that. And then our fluid resuscitation is calculated using a 3-to-1 rule. So 3 mLs of the crystalloid solution for every 1 ml of estimated blood loss. Keeping in mind, if it is greater than 30%, fluids alone won't cut it. We have to replace the blood volume. So septic shock, same thing. We're going to be giving, lots of fluid replacement. Also going to be using some vasopressors. If fluids and the vasopressors don't work to help with the blood pressure, then we can give IV corticosteroids. And what those are kind of doing is counteracting that inflammatory response and that fluid permeability that's moving out of, where it's supposed to be. So we can give steroids to help with that. Okay, related to antibiotics, so we need to get a culture and sensitivity immediately, and how we do that is we would culture everything. So we want to culture the sputum, we want to culture any wounds, we want to culture the urine, and if they have a catheter inserted, we would take the catheter out, cut off the tip, culture the tip of the catheter, those types of things. Once on blood cultures ×2, blood cultures should be done 10 minutes apart from 2 different sites. Once those are drawn and gathered, we can start an antibiotic, but it's going to be a broad spectrum. So something like, cephalosporin or, for your vancomycin or gentamicin, paying attention to kidney function. And then once the causative organism is identified, in a CNS report, it will show that some bacteria are resistant, which, that antibiotic would not be a good choice. We want to look at the antibiotic that the majority of the bacteria are sensitive to, and then they'll start that one for the patient. Okay, glucose levels, we want them less than 180, but not below 140. Reason being, we want to keep it slightly elevated because that glucose is, helping the body do some work. Stress ulcer prophylaxis, we're going to give that Protonix and then DVT prophylaxis as well. Focusing specifically on neurogenic, so spinal stability at the level of injury. We want to make sure that when we give fluids that we're careful with that because, again, this was that hemodynamic phenomenon. There's really no explanation for the fluid, for that blood pressure being low, like they didn't lose any fluid. So we can start fluids, but not bolusing the way that we would be doing with some of the other shocks. And then monitoring for hypothermia because of that poikilothermia. So we want to give, warm blankets, take frequent temperatures, potentially give atropine for the bradycardia as well. So anaphylactic shock, our goal is epinephrine IM. Epinephrine also comes in an inhalant or an aerosolized form. However, the IM is better because if there's a bronchoconstriction, they might not be able to get enough of it in through that way. Also want to give some Benadryl. Ranitidine is a histamine blocker. So those medications are going to help with that inflammatory response. and then bronchodilators. The thing about epinephrine is it is a vasoconstrictor, which some people might think, well, if there's already some constriction going on, why would we want to give a vasoconstrictor? What it actually does is it constricts the blood vessels that are that fluid is moving out of, causing that laryngeal edema. So it helps prevent that, and then it also acts as a bronchodilator. So it's vasoconstricting not the bronchial, but the vessels surrounding it to decrease that edema formation. So neurologic status, we're going to assess orientation, level of consciousness, clinical manifestations, if they have any anxiety, disorientation, confusion, reduce noise and light levels in the ICU, and then also keep a day-night cycle. So try to cluster activities during the day so that the patient can sleep during the night. Monitoring of the cardiovascular status, we're monitoring the EKG, blood pressure, CVP or PA pressures if available, also the arterial blood pressure, monitor for dysrhythmias, treating the hypotension with Trendelenburg. So this was an old technique. It was thought that if we put the patient on their head that this would increase cerebral perfusion, but it was actually been showing to cause patients to have pulmonary edema and go into flash pulmonary edema. So that's no longer used. If they do have that relative hypovolemia where there's fluid in the body, then we're looking at anasarca. There might be some murmurs, that S3 sound. Respiratory status, we're looking at the respiratory rate, depth, rhythm. Is it even and unlabored? Is it shallow? Are they tachypnic? Are they using accessory muscles? Nasal flaring? Want to listen to lung sounds? Monitor pulse ox continuously. ABGs are going to be done, especially if they're mechanically ventilated. Then there's typically a routine order for ABGs. Renal status, creatinine is going to be your best indicator of kidney function, and then we're also going to be looking at the urine output. For body temperature and skin changes, so this is really important with neurogenic shock because they have that inability to control their body temperature, and they also have that dry, flaky skin. With septic shock, they might be flushed and clammy, and then also have a temperature. Other things we want to assess are color, if there's any cyanosis, and then goosebumps. So GI system, we're going to auscultate bowel sounds, want to make sure that they are active. They might be hypoactive in all quadrants, and that's an expected abnormal finding. NG drainage, if we have a patient that has an NG tube in for decompression, we want to look at the characteristics of that drainage. And then if they are having bowel movements, we want to assess those as well. Personal hygiene, we're looking at total care, so bathing, turning every 1 to 2 hours, and then passive active range of motion, and then other types of devices such as the Prafo boots might need to be used, SCDs as well, anti-embolism stockings. For our psychosocial support, we want to give medications for anxiety, keeping in mind that some of them do have respiratory effects. Always communicate with the patient everything you're doing and why, even if they're ventilated and sedated, we still want to provide clear explanations of everything, but in layman's terms as well. If we start hitting the refractory stage of shock, visit from chaplain, family involvement, and having those conversations about withholding care. Also provide privacy, call light within reach, bedside table, all of those things. So we talked about identifying the cause of the shock. So it's really important that we correct the precipitating cause. So if it's neurogenic shock, they're going to give the steroids. They're going to provide support while they're recovering from that. Hypovolemic, we're replacing that fluid. Cardiogenic, we're fixing whatever the issue was, whether it be MI or, valve disorder. And then trying to catch shock, especially sepsis, in the early stage so that we can treat, that infection early on with the appropriate antibiotics before it becomes widespread. And then providing some patient teaching focusing on prevention of reoccurrence. Okay, so we have a question here. It's discussing a patient, if they have progressed beyond the compensatory stage of shock, what would occur? So our answer to this one, if you're reading through it, so increased blood glucose levels, this might happen early on because of the stress response. Increased serum sodium levels would increase early on because of that renin-angiotensin system. Increased serum calcium isn't related to shocks. So our best answer is going to be D, increased serum potassium levels. And the rationale behind this is because after that compensatory stage, we start seeing that increase in anaerobic metabolism, so the increase of lactate, and then that cellular death liberates that intracellular potassium. So we're going to see a patient having some hyperkalemia. Hyperkalemia also occurs with acute kidney injury and with that metabolic acidosis as well.